Let me present you with 3 cases that will challenge what you think you know about some very common overdose presentations. Case 1. You walk into a campus convenience store to find a 23-year-old college student, agitated and confused. Heart rate 140, blood pressure 160/95, temperature 101.2 degrees. Pupils are dilated to 7 millimeters. Skin is flushed and completely dry despite the hyperthermia. It's easy to fall into the trap of assuming this is just a sympathomimetic overdose. And you wouldn't be alone in that trap, but you'd be wrong. What's the one critical assessment finding here that unlocks this case? Case 2, you were called to a house with a dimly lit living room to find an unconscious patient with pinpoint pupils and slow respirations. You administer naloxone, nothing happens. The patient remains apneic. What common medication mimics an opioid toxidrome but could kill your patient if you miss the diagnosis? Case 3, a patient is dropped off in front of you by friends who do not stick around to provide background information. It appears to be a straightforward benzodiazepine overdose. Sedated, normal pupils, stable vitals, but suddenly they're off the ground, screaming and swinging at you and your partner. There's one subtle etiology of this type of presentation that, if not anticipated, could lead to sudden, violent agitation that puts you and your entire crew at risk. These aren't theoretical scenarios. These are the real-world presentations that separate competent medics from exceptional ones. And by the end of this presentation, you'll know exactly how to identify and manage each of these challenging cases. Knowledge is power, and the more you understand the subtle differences in varying toxidromes, the better care you provide. But I'm going to let you in on a secret. When it comes to toxicology, there's a single principle I fall back on again and again. It's like a cheat code that will help you when you don't actually know what they took. Welcome to Loud and Clear EMS Guiding Principles. I'm Ross Orpit. I'm a recovering paramedic, now emergency physician with a subspecialty in EMS. We have 3 learning objectives for today. First, the tox exam. You need to learn and master the systematic approach to toxicological assessment. But don't worry, it's simple, and you'll know exactly what to do after today's episode. I will reveal the 5 critical assessment findings that will help you crack the code to the toxidrome. Second, we'll cover each toxidrome in detail, in addition to the evidence-based treatment algorithms for each. And third, and finally, I'll show you 3 diagnostic pitfalls that even experienced medics fall into. Scenarios where the obvious diagnosis is wrong and the real answer could surprise you. Before we dive into the specific toxidromes, there's a foundational concept that you need to learn to master these calls, and that is the tox exam. The term toxidrome combines toxin and syndrome. That's because a toxidrome is defined as a constellation of signs and symptoms that are characteristic of a class of toxins, i.e., various poisons or drugs. The clinical significance of knowing and identifying the major toxidromes cannot be overstated. In toxicological emergencies, we often lack definitive information about the specific agent involved. Patients may be unconscious, historians on scene are often unreliable, or the actual exposure may be unknown to bystanders. Toxidromes provide us with a systematic approach to categorizing these patients based on physiological findings rather than specific drug identification. From a pathophys perspective, toxidromes represent the body's response to disruption of specific neurotransmitters. Understanding this allows us to predict the clinical course and select appropriate interventions. Today, we'll focus on 4 major toxidromes that represent the vast majority of poisoning presentations. You'll encounter first the sympathomimetic toxidrome, caused by agents that enhance the sympathetic nervous system. Second, the anticholinergic toxidrome, resulting from the blockade of acetylcholine at muscarinic receptors. Third, the opioid toxidrome, due to a mu-opioid receptor agonism. And then finally, the sedative hypnotic toxidrome, primarily from GABA receptor enhancement. Note that We're not covering the cholinergic toxidrome in detail today, as it's primarily seen in occupational exposures to organophosphates or chemical weapon scenarios requiring specialized hazmat responses. These are rarer calls. We did, however, discuss this in detail during an interview with toxicologist Dr. Nick Matzler if you're interested in learning more about this specific toxidrome. In addition, there are many more less common toxidromes like serotonergic, calcium channel blockers, beta blockers, carbon monoxide poisoning, and many others. If you want to learn more about those, you can check out these videos or check out our toxicology playlist after you finish this one. The toxicological assessment. What is the tox exam? And how is an effective toxicological assessment different from our standard medical exam? Here are the 7 essential components of a toxicological assessment. Number 1, scene assessment. You're looking for environmental clues, medication bottles, drug paraphernalia, chemical containers, or unusual odors. But here's what most medics miss. Multiple patients with similar symptoms should immediately raise concern for environmental contamination that could affect you. The emergency department you're delivering this patient to doesn't have access to the scene or bystanders, so you are their only chance to obtain this information. Number 2 is enhanced history gathering. While the patient may be unreliable, there's one additional question you should ask bystanders that can often be revealing. What was the patient doing in the hour before their symptoms started? This single question provides some key diagnostic clues. 3, vital signs. Yes, you take vitals on every patient, and while the heart rate, blood pressure, and respiratory rate are all a piece of the puzzle with these patients, one vital sign you may not often obtain on most patients is a temperature. Many toxidromes present with characteristic temperature abnormalities that help guide treatment. If you don't carry a thermometer, that's okay. A simple back of the hand check can suffice. Do they feel super hot or super cold? Pay attention to that and treat accordingly. We'll talk about how in the next section. Number 4, the diagnostic pupil exam. Most simply, are the pupils big or small? This is perhaps the most diagnostic single finding in toxicology, but you're not a simpleton. Communicate that like a professional. Mydriasis or mydriatic pupils equals big. Meiosis or meiotic pupils equals small. Use medical terminology. Number 5 is the tox handshake. This is different from the trauma handshake, and I don't know why in medicine we're obsessed with sticking our hands and fingers in weird places and calling it a handshake, but we are. So here's what the tox handshake is and why it's important. With a gloved hand, palpate the patient's axilla. This provides immediate information about perspiration status. Does your glove come out drenched in sweat or dry as a bone, not a drop of moisture? In the next section, we'll talk about why this single finding distinguishes between 2 different toxidromes that otherwise present almost identically. Number 6 is a neurological assessment focused on consciousness patterns, muscle tone, and clonus. Look for specific patterns. Is the patient level of consciousness consistent or alternating between sedation and agitation? This distinction will become crucial when we discuss one particular toxidrome that can be fairly challenging to manage because of the wild swings that occur. In addition, are they as rigid as a backboard or as floppy as a sheet? A patient who is altered or unconscious but stiff as a board is a much different patient than an unconscious patient without muscle tone. The former can be concerning for syndromes such as neuromalignant syndrome, NMS, or serotonin syndrome, and the 2 of those can be distinguished by presence or absence of clonus. If you forcefully dorsiflex the ankle, do they reflexively tap their foot back at you for more than just a few beats? This is called clonus. A few beats of clonus can be normal, but any more than that can be concerning, and if the clonus is sustained, meaning it never stops until you let go, or spontaneous, that can be life-threatening. Clonus is most commonly associated with serotonin syndrome, but can be seen in severe sympathomimetic overdoses, especially if the patient is also on a selective serotonin syndrome reuptake inhibitor, or SSRI. Again, we're not going to get any further into NMS or serotonin syndrome in this episode, but we've covered it in the past, so go check out our serotonin syndrome episode to learn more about both of these. Lastly, number 7 is assessing for bowel sounds. Again, not something you or I, for that matter, tend to incorporate on our standard medical exam, but different toxidromes produce characteristic patterns of intestinal activity, hyperactive or hypoactive, and this finding can often help confirm your clinical suspicion. Master and use the components of the tox exam, and it will increase your diagnostic acumen on your next drug overdose, where no one can tell you what the patient actually took. So let's dive into our first toxidrome. But you remember that patient I mentioned who seemed like a straightforward stimulant overdose, but had one crucial finding that changed everything? We'll come back to that case in just a moment. The sympathomimetic toxidrome results from substances that enhance your sympathetic nervous system, hyperactive, heart, brain, temperature, pupils, sweat glands, bowels. Let's get into each of these. Here are the 6 classic presentations you need to recognize. Number 1, cardiovascular hyperactivity. Let's break that down. Tachycardia, often exceeding 120 beats per minute. Hypertension, systolics greater than 150 and diastolics greater than 90. And look out for potential dysrhythmias, particularly with cocaine, which can cause a sodium channel blockade, widen your QRS until your rhythm decompensates. This is a very unique finding that gets treated with sodium bicarb until that QRS narrows. And for a deeper dive into this, check out our cocaine toxicity episode with toxicologist Dr. Leslie Pepin. Number 2, neurological excitation, agitation, hypervigilance, anxiety, and in severe cases, paranoid psychosis with delusions. Number 3, hyperthermia, elevated body temperature due to increased metabolic rate and muscle activity. This is important because hyperthermia is actually the number 1 predictor of mortality in this overdose, and it requires aggressive treatment. You can certainly try external cooling measures if time allows, but this should not be your primary focus because the hyperthermia is just a sign of the ongoing sympathetic overactivation that we need to shut down. We'll talk about how to do that in just a sec. But number 4, mydriasis, pupil dilation out of proportion to the level of lighting in the room, typically in the range of 6 to 8 millimeters. Number 5 is diaphoresis, and this is absolutely critical. In a sympathomimetic overdose, these patients are sweating profusely. If they're not, if they're bone dry, we'll talk about that in our next toxidrome. Number 6, gastrointestinal hyperactivity, hyperactive bowel sounds due to increased intestinal motility. This is another distinguishing feature between this and our next toxidrome. Here are the 3 most common substance classes that cause sympathomimetic toxidrome. Class 1 is amphetamines, including methamphetamine, MDMA, and therapeutic stimulants. Class number 2 is cocaine with its unique cardiac risks, as we discussed above. Class number 3 is synthetic stimulants, including bath salts and novel psychoactive substances. Our treatment follows 3 essential principles. Principle 1, benzodiazepines for sedation. Lorazepam, 2 to 4 milligrams IV, or midazolam, 5 to 10 milligrams IM. This is going to assist in shutting down the sympathetic nervous system. Principle 2 is aggressive temperature management, because hyperthermia is the number 1 predictor of mortality. It is unlikely the temperature that kills them, though. This is just a sign that metabolic system is still out of control and in overdrive. And how do we shut that down? Refer to principle 1, benzodiazepine. If the overdose is so severe that they are hyperthermic, tachycardic, and hypertensive despite your usual doses of benzodiazepines, don't be surprised. In severe overdoses, these patients often require some whopping doses of benzos. We're going to treat an overdose with an overdose here. So don't be afraid to call into medical control for additional doses above and beyond your protocols until you see the vital signs start to normalize. Principle 3 is if you see QRS widening or a tall R wave in AVR, think cocaine overdose. Think sodium channel blockade, give sodium bicarb until that QRS narrows. But here's what connects all of this. What if that agitated tachycardic patient with dilated pupils isn't sweating? That changes everything. And it's the first clue to our second toxidrome, anticholinergics. The anticholinergic toxidrome, and this is where that critical assessment technique, the tox handshake, becomes vital. And those bowel sounds you rarely listen to will help you confirm your suspicions as well. Remember our first case, the agitated patient who looked like a stimulant intoxication but had one crucial difference? Here's why. There's a key difference. Sympathomimetic toxicity is because of a direct activation of the sympathetic nervous system, whereas anticholinergic toxicity is a form of blockade of the parasympathetic nervous system, which relies on the neurotransmitter acetylcholine. The parasympathetic is meant to counterbalance the sympathetic. When you lose that counterbalance, you experience a very similar effect, but with one big difference and some subtle other differences. Here's the 5-component mnemonic that helps highlight the unique characteristics that differentiate this from a sympathomimetic overdose. Mad as a hatter, red as a beet, dry as a bone, blind as a bat, hot as hell. Component 1, mad as a hatter. Altered mental status, ranging from mild confusion to frank delirium with visual hallucinations. But here's how to help distinguish this from agitation caused by sympathomimetics. I had an attending once tell me, if they're screaming at you and you can make out clear as day every profanity they're screaming at you, this is likely a sympathomimetic. Conversely, if it's a bunch of gibberish that makes no sense at all, this is likely an anticholinergic. Component 2, red as a beet. Characteristic flushed erythematous skin due to vasodilation. This will be even more pronounced than what you'll see with any other run-of-the-mill stimulant. Component 3 is dry as a bone. And this is the critical difference the tox handshake clues you into. The complete absence of sweating despite their hyperthermia. This is because our sweat glands are controlled by the M3 muscarinic receptor, and they require activation by acetylcholine in order to induce perspiration. This is blocked in an anticholinergic overdose, but unaffected by a sympathomimetic overdose. Component 4 is blind as a bat. This is the mydriasis with pupils often 8 millimeters or greater. Component 5 is hot as hell. Severe hyperthermia that can be life-threatening because these patients cannot cool themselves through perspiration. Here are the 4 most common sources of an anticholinergic poisoning. Source 1 is antihistamines, particularly diphenhydramine in recreational or overdose situation. Source 2, tricyclic antidepressants. Tricyclics are rarely used anymore, but if you do see a TCA overdose, these can have very profound anticholinergic effects. And just like cocaine, they can block your sodium channels in the myocardium, leading to a tall R wave in AVR and widening of the QRS. This is treated with sodium bicarb and titrated again to that QRS narrowing. Source 3 is antipsychotic medications, either in intentional overdoses or even in therapeutic dosing errors. Source 4 is plant sources, Jimson weed, nightshade, and other botanical intoxications. But here's a hot tip. They can drastically reduce the agitation seen in the anticholinergic toxidrome. The smooth muscles of the bowel and bladder rely on acetylcholine activation of the M1 and M3 muscarinic receptors. Anticholinergic toxicity leads to the smooth muscle paralysis. So not only will they have hypoactive bowel sounds, whereas sympathomimetics will lead to hyperactive bowel sounds, they will also have urinary retention. Think back to the last time you held your bladder for too long. Did you have much patience for any questions that were being asked of you? That's exactly what these patients may be experiencing. So if you see ongoing hyperactivity and agitation despite adequate doses of sedatives and improvement of your vital signs, oftentimes draining the bladder drastically improves the patient's agitation. Treatment involves 3 interventions, with the possibility of a 4th in very rare and severe cases. Because this specific antidote can be life-saving, yet dangerous if used incorrectly. Intervention 1 is benzodiazepines. This will be your mainstay of therapy. Titrate to both agitation and abnormal vital signs. Lucky for us, this is the same dosing as sympathomimetic toxidrome. So even if we think it is a sympathomimetic when it's actually an anticholinergic, benzos are still the primary treatment. However, when it comes to antipsychotics such as droperidol, these medications may be safe and effective for controlling agitation in a sympathomimetic overdose, but they can actually have significant anticholinergic properties and can actually worsen an anticholinergic toxidrome. If you're unsure between the two toxidromes, stick with benzos. But if you understand the principles discussed earlier, you should be able to figure it out. Intervention 2 is aggressive external cooling for any hyperthermia, because that acetylcholine blockade at the sweat glands is preventing these patients from regulating their own temperature with perspiration. Intervention 3 is urinary catheterization when retention is present. You're probably not going to be doing this in the back of the ambulance, but may be required upon arrival to the ED when it is safe to do so. And that fourth intervention, physostigmine, may be considered, but only in severe cases of pure anticholinergic toxicity that is refractory to benzodiazepines. Physostigmine is an anticholinesterase inhibitor, so it prevents the breakdown of acetylcholine at the nerve synapse. This increases the concentration of acetylcholine, allowing it to overcome the anticholinergic blockade. However, note, this is the exact same medication of organophosphate poisoning and can lead to dangerous complications. So it is not first-line therapy, and rescue agents such as atropine should be at the bedside if it's going to be used. Remember, the key to distinguishing this from a sympathomimetic toxidrome is the toxicological handshake. Sympathomimetic patients are soaked with sweat. Anticholinergic patients are bone dry. Now, what about that second case I mentioned? The unconscious patient with pinpoint pupils who doesn't respond to naloxone. That's where our understanding of the opioid toxidrome becomes critical, because there's a common imposter that mimics opioids but kills patients when it doesn't respond to naloxone and we don't act appropriately in response. The classic opioid toxidrome represents 3 cardinal features, but there are 2 common imposters that presents with similar features and can fool even experienced medics. Feature 1 is your central nervous system depression, from somnolence to complete unresponsiveness. Feature 2 is respiratory depression, the life-threatening component with decreased rate and shallow breathing. Feature 3 is our meiosis, those pinpoint pupils that are out of proportion to the level of lighting in the room, typically 1 to 2 millimeters. Opioids are generally broken into 3 classes. Natural opioids such as morphine, codeine, opium, which are made from the seed pods of the opium poppy plant. These natural substances are also known as opiates. Semi-synthetic opioids, such as heroin and the pain relievers oxycodone, hydrocodone, and hydromorphone, are made in laboratories by chemically processing natural opioids. Synthetic opioids, such as fentanyl, carfentanil, are manufactured entirely in laboratories with no natural ingredients. Opioids differ in their strength or potency. Generally, the more synthetic the opioid, the more potent. Now, when it comes to what saves lives, naloxone. There are 3 essential principles that I want you to remember. Principle 1, and this is the most important, this informs the rest of the principles. The goal is respiratory restoration, not full consciousness. Principle 2, start with 0.4 to 0.5 milligrams and titrate to breathing, not alertness. Principle number 3, reserve 2 milligram slugs for cardiac arrest or peri-arrest only. There's some controversy as to whether naloxone is required in cardiac arrest, because if you're already correcting the breathing with your advanced airway maneuvers you perform during cardiac arrest management, then you have essentially fixed the respiratory cause of the arrest by breathing for them. However, a recent retrospective cohort study by Dillon et al. Showed a significant increase in neurologically intact survival with the use of naloxone in cardiac arrest. This study is extremely limited by its retrospective, non-randomized nature and is far from a definitive answer to this question. But for now, I'm giving naloxone in my presumed opioid-induced cardiac arrests. Why does this matter? Why do we want to be judicious with the amount of naloxone we give and have a clear understanding of what we are titrating to? Well, if we give too much naloxone too fast, you'll precipitate withdrawal syndrome that can include vomiting and agitation that is just no fun for anyone involved. A breathing but sleeping patient is much easier and safer to take care of than an agitated vomiting patient. In addition, there is a rare but serious complication of flash pulmonary edema. The mechanism behind the induction of flash pulmonary edema after a slug of naloxone is not well understood, but one of the leading theories is it induces a big, forceful respiration against a closed glottis. And that leads to such negative intrapulmonary pressures and leads to a massive shift of fluids from the vasculatures into the lungs. If this occurs, the management is non-invasive positive pressure ventilation, titrated to hypoxia and work of breathing. But what happens if you're giving repeat doses of naloxone, totaling 2-4 milligrams, and you're not seeing any correction of the respiratory depression? Here's the answer to our mystery case in the beginning. What mimics opioid toxidrome but doesn't respond to naloxone? Alpha-2 agonists like clonidine. They cause identical presentations, unconsciousness, respiratory depression, and pinpoint pupils, with the hallmark being a lack of response to naloxone. Fail to recognize this and your patient dies while you're wondering why naloxone isn't working. The fix here is airway management. Support their respirations with mechanical ventilation until the drug wears off. In these overdoses, the alpha-2 agonist overdoses, you may also see profound bradycardia and hypotension. This similarly gets managed supportively with vasopressors like epinephrine drip, which will increase both heart rates through beta-1 receptors in the heart and vascular tone through the alpha-1 receptors in the arterioles. The key differential point: if naloxone doesn't improve your respiratory status after appropriate dosing, consider clonidine or other sympatholytic agents, such as our next category, the sedative hypnotic toxidrome. Now, that third case I mentioned, the seemingly straightforward sedative overdose with a hidden danger that could put your crew at risk, that's where the understanding of sedative hypnotic toxidrome and the different drugs that cause this toxidrome becomes crucial. Sedative hypnotic toxidromes present with 4 key characteristics that distinguish it from an opioid toxidrome. Characteristic 1, you have that CNS depression, but with a preserved respiratory drive, unless the overdose was massive. Characteristic 2, normal pupils, not pinpoint like opioids. Characteristic 3, that normal respiratory rate, again, unless massive doses or co-ingestions are involved. Characteristic 4 is stable vital signs, normal blood pressure and heart rate. The 4 major drug classes causing this toxidrome are class 1, benzodiazepines, like your alprazolam, lorazepams, diazepams. Class number 2, your non-benzodiazepine sleep aids. These are your Z drugs, such as zolpidem. Class number 3, barbiturates, commonly abused recreationally in the 90s. They've been on a steady decline since then and accounted for only 2 single ingestion agent deaths reported to poison centers in 2009. They are still commonly used as anticonvulsants clinically though. Class 4, your gamma hydroxybutyrate, or GHB. And here's the answer to our mystery case in the beginning. Unlike other sedative hypnotics, GHB can cause alternating periods of deep sedation with sudden violent agitation. One moment your patient is unconscious, the next they're combative and potentially dangerous to you and your entire crew. And when I say deep sedation, I mean deep sedation. These patients may have periods of apnea. Generally, these apneic episodes are short-lived, and if you can briefly support them through it, it will self-resolve. But occasionally, you do have to intubate them. I remember my first case of a GHB overdose. A private vehicle came screaming into the ambulance bay at the hospital and pushed a 20s male out of the vehicle and yelled at paramedics, "My friend needs your help," before rushing away. Paramedics pulled out their stretcher, threw this guy on it, and brought him into the ED. He arrived unconscious, GCS of 3, and then suddenly just stopped breathing. Despite the normal sized pupils, we still administered a trial of naloxone with no effect. So we started to prepare for intubation. Literally, as we are pushing the paralytic, the patient suddenly sat up and started kicking and screaming. 15 seconds later, the etomidate and sucks kicks in and he lays back down, sedated and apneic again. We now realize we're likely dealing with GHB, but we've already given the paralytic and he's at risk for further episodes of apnea, so we proceed with the intubation and keep him sedated and intubated for the next few hours as the GHB wears off. If he had awakened before the paralytic, we probably would have tried to hold off on intubation to see if we could support him through these apneic episodes. Depending on how frequently they were occurring and for how long, it may have become too dangerous and resource intensive, and we may have had to still intubate him anyways. Here's the 3-point management approach to the sedative hypnotic syndrome. Point 1, airway management, with positioning and adjuncts as needed. Point 2, supportive care. Mechanical ventilation is rarely required. Airway and breathing are really your biggest risks with sedative hypnotics, but it's rare and usually only happens in large ingestions or in co-ingestions. Point 3 is there is an antidote you can consider, flumazenil. It exists for benzodiazepines, but it carries a significant risk, so it is rarely used or recommended. Why don't we routinely use flumazenil as an antidote for benzo overdoses? First, it can precipitate seizures in benzodiazepine-dependent patients. Second, its duration of action is shorter than many benzodiazepines, leading to a resedation when it wears off. Really, the biggest thing is just airway management and supportive care, and allow them the medicine of time to metabolize the drug. The key diagnostic point for sedative hypnotics, profound sedation with normal vitals and exam. Normal pupils and normal respiratory rate distinguish this from our opioid toxidrome. But what happens when these clear-cut presentations don't match what you're seeing? That's where understanding the most dangerous diagnostic pitfalls becomes essential. Error 1 is the obvious opioid trap, assuming all unconscious patients with small pupils are opioid overdoses. Remember our clonidine or alpha-2 agonist case? Identical presentation, zero response to naloxone. Always consider alpha-2 agonists when naloxone fails, especially if you're also seeing bradycardia and hypotension. Error 2 is the stimulant assumption, seeing agitation and tachycardia and immediately thinking sympathomimetic. But if they're not sweating, you're dealing with an anticholinergic toxidrome, which requires different cooling strategies because these patients can't thermoregulate. Admittedly though, even if you fall into this trap, the good news is the treatment is mostly the same for both. Benzodiazepines for sedation and to shut down the metabolic overdrive that is causing the hyperthermia. The key difference is you want to avoid antidopaminergics like droperidol or haloperidol, as they have anticholinergic properties and are fine for stimulant overdoses but can worsen an anticholinergic toxicity. Error 3, the single agent trap. Assuming patients took only one substance. Polypharmacy ingestions create blended presentations that can mask life-threatening conditions. The agitated patient might have both stimulants and opioids on board. Suddenly you've blocked the stimulants with your benzodiazepines, and now you have both a GABA and mu receptor antagonism, leading to profound respiratory depression. The key is don't fear the treatment. Respect the treatment. When you apply a sedative, apply full cardiorespiratory monitoring so that you can identify any problems early and address appropriately with supportive measures. When presentations don't fit classic patterns, here are 4 considerations. Consideration 1, mixed ingestions creating atypical presentations. Co-ingestions like alcohol can modify our typical findings. Consideration 2, time course effect. Early versus late presentations differ significantly. Consideration 3, tolerance effects in chronic users. And consideration 4, novel synthetic substances with unpredictable effects. Here's your systematic diagnostic algorithm in 6 steps. Step 1, ensure scene safety and rule out environmental contamination. Step 2, address immediate life threats with standard resuscitation and supportive care. Here is a secret and the beauty of toxicology acute resuscitation phase. Oftentimes, you do not need to know what they took. You just need to respond to what you're seeing. If they're not breathing, give naloxone, and if that doesn't work, breathe for them. If they're out of control agitated, calm them down with benzodiazepines. If they're hypotensive or bradycardic, give them epi. If they're sleeping but otherwise have normal vitals, then let them sleep and keep a close eye out for any changes in the vitals. Step 3, check a blood glucose. Step 4, perform the systematic tox exam I outlined earlier. Step 5, identify the most likely toxidrome based on pattern recognition and notify the hospital. Step 6, initiate toxidrome-specific interventions if not already initiated in step 2. All right, let's resolve those 3 cases from our opening and cement your understanding with the key clinical pearls. Case 1, the agitated college student, anticholinergic toxidrome. The dry skin, despite the hyperthermia, was the clinical differentiator. Treatment requires aggressive benzodiazepines and, if time allows, external cooling. Case 2, the unconscious patient with pinpoint pupils but unresponsive to naloxone. Clonidine poisoning mimicking an opioid toxidrome. The clue was the lack of naloxone response. In addition, further clues may be bradycardia and hypotension. These patients require supportive care and mechanical ventilation if there is respiratory insufficiency, and vasopressors if there is bradycardia or hypotension. Case 3, the seemingly simple sedative overdose. GHB intoxication. The hidden danger was the potential for sudden violent agitation alternating with unconsciousness. Here are the 5 essential clinical pearls to improve your toxicological practice. Pearl 1 is the tox handshake. Sweating status instantly differentiates our sympathomimetic from anticholinergic toxidrome. Pearl 2, pupil size, is relative to the environment that you are in. Focus on the discrepancy, larger than expected for the bright environment or smaller than expected for the dark environment. Pearl 3, your naloxone goal is breathing, not consciousness. Titrate to respiratory effort, not wakefulness. Pearl 4, be prepared for mixed ingestions that may be unmasked by your initial treatment. And Pearl 5, for patient safety with agitated toxidrome patients, remember the 3 principles of restraint use. Principle 1 is chemical sedation is superior to physical restraint in most cases. Principle 2, if physical restraints are necessary, avoid positional asphyxia. Principle 3, full and continuous cardiorespiratory monitoring is essential as these patients can deteriorate rapidly. Remember, toxidromes provide systematic approaches to poisoning when specific agents are unknown. Master these patterns and you'll provide evidence-based care even in the most challenging toxicological emergencies. The difference between competent and exceptional medics lies in pattern recognition and a systematic assessment. You now have both tools at your disposal.